In this question here, we're to determine which of the following answers is most likely to be the first early sign of cutaneous radiation injury. So this is a term that is used to describe symptoms that occur following exposure to radiation. And in those receiving radiation therapy as treatment for cancer, 90% of them will experience cutaneous radiation injury. So it's important to know what these symptoms look like in patients so that we can quickly diagnose them and treat them. And if we do see this occurring in dentistry, it's likely that these patients have received radiotherapy of the head and neck, which is causing radiation injury to the oral cavity and surrounding structures as well. And the structures that are most likely to be affected are those that proliferate quickly. So this does involve the skin, and we'll be discussing several symptoms of radiation injury to the skin. So the correct answer here is transient erythema, and this is the first sign of cutaneous radiation injury and can appear hours following the radiation dose up to 2 weeks following exposure. And the higher the dose received, the longer the erythema will persist on the skin. And this just marks the beginning of acute radiation skin injury. So one of the most commonly used scoring systems for radiation injury is the toxicity criteria for the radiation therapy oncology group. So we can see here in stage 0, there's no change in the skin, and stage 1 is the first symptom to occur is erythema. So following erythema, we'll also see edema as well as pigment changes. So therefore, these two answers are incorrect. However, if the radiation dose is high enough, edema can occur at the same time as erythema. So ulceration will typically only occur if moist desquamation does not occur, and we'll see this in chronic radiation skin injury, and this can also occur along with fibrosis. So therefore, the first sign to occur following cutaneous radiation injury is erythema.
We have a 52-year-old female who says, I'm here for my cleaning. She's a smoker with a 10-pack year history. She has Sjogren's disease, celiac disease, she's taking some medications, and she also has dry mouth and several class 5 caries. And we're being asked, celiac disease is a disease of which of the following? The skin, the stomach, the small intestine, or the large intestine? Now this question is obviously focusing on celiac disease, which is a condition that I'm sure you've at least heard of. This would be an immune condition that results when the patient eats gluten, which refers to anything made from wheat or other grains such as breads, cereals, and pastas. If someone with this condition does consume gluten, the body triggers an immune response to that gluten protein, causing damage to a specific organ, which we'll come back to, diarrhea, fatigue, weight loss, or nausea. Other symptoms include anemia, osteoporosis, aphthous ulcers, headaches, and joint pain. Complications of the condition include malnutrition, bone weakening, infertility, and even cancer. There is no cure for the condition, and the main treatment would obviously be maintaining a strict gluten-free diet. But back to the question, celiac disease is a disease of which of the following organs? That would be C, the small intestine. When someone with celiac disease consumes gluten, the body triggers an immune response to that gluten protein in the small intestine, leading to intestinal damage. This makes sense if you think about it because the small intestine's primary function is to break down food and absorb nutrients. This is where whatever the person ate is broken down and the gluten protein is exposed, causing the body to attack the lining of the small intestine where the gluten protein is present. Now, before moving on to discussing the other answer choices, I also want to point out that this condition is more common in women, such as our patient, and that it's also linked to an association with other autoimmune conditions, such as Sjogren's disease like we see in our patient. But now, let's go through the other answer choices and briefly discuss some conditions that might affect those organs. We know they are all incorrect answer choices because celiac disease is not a disease of those organs and the body does not attack them in response to gluten. And we'll start with the skin. Now, although celiac disease is not a disease of the skin, patients with celiac disease can present with symptoms on the skin, such as an itchy and blistery skin rash known as dermatitis herpetiformis. This is a separate autoimmune condition that can occur also in response to gluten, but it is also often seen in patients with celiac because the immune system is already triggered by the gluten protein. So it makes sense that if your small intestine in your body is being reactive to this gluten, that your skin would be reactive to it as well, but these are two separate conditions. Like I said, because this is not the organ primarily affected by celiac disease, this answer choice would be incorrect. Next, we have the stomach. Now, if you didn't know much about celiac disease, you may have considered this as a correct answer choice. Maybe the person eats gluten, it causes an upset stomach, and that's why they have symptoms, but that would be incorrect. A patient with celiac disease can certainly have digestive symptoms like stomach pain or bloating, but the stomach is not the organ that is directly being affected in this disease, and that is why this answer choice is incorrect. The small intestine is the organ being attacked by the immune system, not the stomach. And then finally, we have the large intestine, and this answer choice may have been the trickiest for you. You may have remembered that celiac disease affects the intestines, but may not have remembered that it affects the small intestine and not the large intestine. To try and keep this information straight, just think about the different roles of the small and large intestine, and it should make some more sense. The small intestine is the portion of the digestive tract that breaks down food and absorbs nutrients, while the large intestine is responsible for absorbing water and electrolytes. It would then make sense that the gluten protein would be exposed in the small intestine after food is broken down, and that is where the immune system would attack the body, not in the large intestine. So since celiac disease does not primarily affect the large intestine, we knew that this answer choice was incorrect. So we know that when we're discussing celiac disease, we know that it is an immune condition of the small intestine that results when a patient consumes gluten. This question is asking each of the following lesions can be caused by a viral infection except one. Which one is the exception? Aphthous ulcers, cold sores, herpetic gingivostomatitis, or oral squamous cell papilloma. So 3 out of these 4 conditions are caused by a viral infection. All of them but one. And out of these answer choices, the one that is not associated with the viral infection is A, aphthous ulcers, and I've attached a picture of what one would look like. This means that cold sores, herpetic gingivostomatitis, and oral squamous papilloma all can be caused by viral infections, and we'll talk more about those causes, what those viral infections are, after we talk about aphthous ulcers. So aphthous ulcers are more commonly known as canker sores, so you've probably heard of a canker sore, and they're believed to be due to an immune-mediated process. They're quite common and are associated with possible triggers such as stress, local trauma, nutritional imbalances, and even your menstrual cycle, but they're not due to a viral infection. They're characterized by a yellow-white round ulceration with the fibrinopurulent membrane and erythematous halo. So that's exactly what we're seeing in this picture. They're also known to cause a burning or itching sensation. These ulcers are found almost exclusively on non-keratinized mucosa and are most common on the buccal and labial mucosa, ventral tongue, floor of mouth, and soft palate. They're usually classified as minor or major depending on their size, the number of lesions present, and how long they take to heal. Because these are believed to be immune-mediated, they are treated with topical corticosteroids and not antivirals. So next, we'll start with a cold sore. And a cold sore is just a common name for a recurrent herpes labialis infection. And because herpes is a DNA virus, this is definitely caused by a viral infection. Herpes simplex has 2 forms, HSV1, that is predominantly oral, and HSV2, which is predominantly genital. To have a recurrent herpes infection, you would obviously have to have a primary herpes infection first. The infection becomes recurrent because herpes simplex is neurotropic and can remain dormant in the sensory ganglia for a while before being reactivated in a recurrent infection. So what we're seeing here is a recurrent infection. It's been reactivated. Now, a cold sore is triggered by UV light exposure or trauma and affects the vermilion zone or perioral skin, as we're seeing in this picture. A patient will experience prodromal itching, tingling, burning, and redness before the lesion appears, and then the formation of a cluster of vesicles. These vesicles will rupture, form a crust, and then heal in about 7 to 10 days. Because this is due to a viral infection, this can be treated with a topical antiviral agent when the patient is experiencing these prodromal symptoms. This may not be necessary though, because the lesion usually resolves on its own. Next, we have herpetic gingivostomatitis. So we just talked about a recurrent herpes infection, that's what a cold sore is, but herpetic gingivostomatitis is actually just another name for that primary oral herpes infection we mentioned when talking about cold sores. So this is also due to the HSV1 form of the herpes simplex virus, and it's spread through saliva. So this is a primary herpes infection, and the cold sore was the recurrent herpes infection. Don't get those two mixed up. Now, clinically, for herpetic gingivostomatitis, the patient will experience acute fever, cervical lymphadenopathy, and oral sores. These oral sores can affect any mucosal surface and begin as vesicles that quickly rupture to form ulcers. These shallow ulcers will coalesce, resulting in larger ulcers that have serpentine borders. This primary herpes infection only lasts 10 to 14 days until it resolves, and treatment is mostly symptomatic care like analgesics. 25% of patients with primary herpes will have a recurrent herpes infection or cold sore like we discussed earlier. So that's how common it is to go from primary to recurrent. Because this is due to a viral infection, this can be treated with an antiviral if it's identified within the first 2 to 3 days. Most of the treatment is usually just symptomatic care, like we said, including analgesics and topical anesthetics. And finally, we have oral squamous cell papilloma. Now, this is a benign growth associated with the human papillomavirus, or HPV. There are many types of HPV, but squamous papilloma specifically is associated with types 6 and 11, which are low-risk types for causing cancer. These papillomas are seen in patients of any age and are not sexually transmitted. Clinically, they are usually pedunculated but can be sessile. They're exophytic, which basically just means that they grow outward beyond the surface epithelium from which the lesion originates. They have finger-like projections, giving them a warty or cauliflower appearance, and they usually are solitary lesions. They're soft and painless, and their color can vary between the shade of the surrounding tissue to more of a white color depending on the amount of keratin present. They're commonly found on the tongue, uvula, soft palate, and lip, but can be seen at any location. These are actually removed via conservative excision rather than treated with an antiviral, and recurrence is unlikely. They can also just spontaneously go away with no treatment. So when we look at these 4 options, each of the following is caused by a viral infection except one. So cold sores are viral, herpetic gingivostomatitis is viral, oral squamous papilloma is viral, but aphthous ulcers are not caused by a viral infection. They're an immune-mediated condition. We have a 7-year-old female who says, I haven't been to the dentist in a couple years. She has depression, hypertension, she's taking a couple medications, and we notice multiple missing teeth and a heavily restored dentition. And we're asked, what is the most likely etiology of this condition? Now, before we can determine the etiology of this condition, we need to determine what this condition even is. And obviously, the most helpful thing that we're given to make this diagnosis is this image. That's really all that we're given to see this lesion and make a diagnosis. And when we look at it, we can see this flat, bluish discoloration on an edentulous portion of the alveolar ridge. We aren't given a lot of additional information in the patient box that we need to make this diagnosis, but there is one huge clue that points us toward the correct diagnosis, and that is the fact that this patient has a heavily restored dentition. Now, based on the presentation of this lesion as flat, due to its pretty unique bluish color and its location right on the alveolar ridge, and especially due to the fact that this patient has a heavily restored dentition, we know that this lesion is an amalgam tattoo. Now, an amalgam tattoo is exactly what it sounds like. It's the result of an iatrogenic introduction of inert pigment, the amalgam, within the connective tissue. It's a tattoo from amalgam. It will present as a flat, blue, black, or gray lesion that is homologous in color and will typically be present in the area where an amalgam restoration was located near. The lesion presents exactly as these tattoos are described, and the fact that the patient has a heavily restored dentition means that there has likely been many amalgams done and many opportunities for loose particles to embed in the connective tissue. Because of this, the etiology of the lesion would obviously be A, deposition of amalgam particles in the tissue. The good thing about this condition is that the diagnosis can basically be confirmed just by doing an X-ray. The particles of amalgam will be visible as radio-opaque specks beneath the tissue. Now, this does not require any treatment and will likely fade over time, just like a normal oral tattoo. Now, although this is the correct answer choice, let's go through the other etiologies, discuss what conditions they cause, and why they're incorrect. And we'll start with exposure to ultraviolet light. Now, too much UV light exposure can have a number of negative effects on the body, but it's most commonly associated as a major risk factor for melanoma, and that's what you're seeing in this picture. This is a malignancy of melanocytic differentiation, and it's the third most common skin cancer. These can be seen cutaneously and mucosally, which means in the mouth, and high-risk sites are the back, arms, neck, and scalp. The common clinical signs for melanoma are known as the ABCDEs: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolving in size or color. There are different types of melanoma depending on their location and their growth pattern, and they can vary in appearance. And treatment for this condition includes surgical excision with a 1 to 2 centimeter margin, as well as close clinical follow-ups. And prognosis depends on the depth of invasion in sight, but can be really poor. Now, we know this answer choice is incorrect for a number of reasons. Firstly, I do want to point out that because melanoma can be seen intraorally, lesions presenting like the one our patient has as that amalgam tattoo are actually sometimes biopsied to rule out an early melanoma. But if we see amalgam particles on an X-ray, then this would really be unnecessary. Melanoma is way more common cutaneously and usually presents as a non-homogeneous brown and black lesion with irregular borders that grows and changes. It typically doesn't present like our patient's lesion, that flat blue-gray lesion right on the alveolar ridge. Also, just logically, the chance that an intraoral lesion is due to UV light exposure doesn't really make too much sense. Now, unless the patient is always holding their mouth open to make sure their alveolar ridge is getting some sun, this etiology wouldn't really be an intraoral concern. And because amalgam tattoos are not caused by this etiology, this answer choice is incorrect. Next, we have failed melanocytic migration from the neural crest to the dermal epidermal junction. Now, this is the very specific etiology for a lesion known as a blue nevus, which is what you're seeing in this picture, and it's a melanocytic lesion that presents as a bluish or blue-gray color due to the depth of the melanin pigment. Now, clinically, these can be seen cutaneously, especially on the hands, feet, scalp, and face, and mucosally, especially orally and on the conjunctiva. These are most common in children and young adults with a female predilection and are less than 1 centimeter in size usually. These are typically treated via biopsy just because it's safe to biopsy all unexplained pigmented oral lesions, better safe than sorry, and the prognosis is excellent. Now, although blue nevi do present somewhat similarly, they're really not found on the alveolar ridge and would not be associated with a heavily restored dentition. When seen intraorally, the most common location is the palate, just like this picture, and these would not show radiopaque particles on an X-ray. Because this is not the lesion we're seeing, and because amalgam tattoos are not due to failed melanocyte migration, this answer choice is incorrect. And then finally, we have abnormal growth and development of a vessel. Now, this etiology describes a vascular malformation or a structural anomaly of blood vessels present at birth. These can vary in color and appearance depending on the vessel they affect, so venous malformations would be blue, while capillary malformations present as a red port wine stain. These also grow proportionally with the patient, and they can occur anywhere on the body. Vascular malformations are usually not associated with other abnormalities, but they may be associated with some rare syndromes, such as Sturge-Weber syndrome. Doing a dioscopy, which involves pressing on the lesion with a glass slide, can help to narrow down the differential diagnosis list because the blood within the vessels will be pushed into adjacent vessels and cause this characteristic blanching of these vascular lesions. But I want to emphasize that this is just not a way to obtain a final diagnosis. It just can help in indicating this. So this is not an end-all diagnosis by doing this, but can help us point in the right direction. Now, although this can present in a similar color to the amalgam tattoo, this answer choice is incorrect because that's really the only similarity between the two lesions clinically. These vascular malformations would be located in very vascular areas and not really right on the alveolar ridge. They're also typically raised lesions that would disappear when blanched and present as more of a blue-purple than a blue-gray flat lesion. Because the lesion does not present as a vascular malformation, what our patient has, and because amalgam tattoos are not caused by abnormal growth and development of a vessel, this answer choice is incorrect. So when you see a flat blue-gray lesion on the alveolar ridge of a patient with a heavily restored dentition, you should always consider an amalgam tattoo as the diagnosis, which is due to deposition of amalgam particles in the soft tissue. This diagnosis can basically be confirmed just by taking a radiograph and looking for the radiopaque particles seen beneath the tissue.
In this scenario, the patient is a 38-year-old male who presents to the clinic because his cheek is becoming more and more swollen. So we do see facial asymmetry and there is no pain, but the patient does present with a radiolucency in the posterior mandible. So given all these findings, the most likely diagnosis is an ameloblastoma. So this is a characteristic soap bubble-like appearance where we can see a radiolucent interior and radioopaque septa throughout. We can see a scalloping in between the roots, so it does have potential to cause root resorption and loosening of teeth sometimes. The swelling can cause asymmetry in the face, which is what the patient presents with, and then we can also sometimes have pain, although oftentimes ameloblastoma will be painless. So we'll take a look at the other options to determine why they are incorrect. First up, we have the dentigerous cyst, and we know that it will be radiolucent because it is a cyst, and it also has the potential to cause facial asymmetry if it grows large. Generally, there is no pain if it's smaller, but if it grows larger, it can cause the facial pain and pathological fracture. We know that this answer is incorrect, however, because a dentigerous cyst is always associated with an unerupted tooth, like we're seeing in the radiograph. But we do know that the patient does not present with an unerupted or impacted tooth, so this answer is incorrect. Next, we have the Staphny bone cyst, and we have a radiograph here that shows us that it is a radiolucent cyst. It is a pseudocyst, so it will appear like one, but it won't have that epithelial lining or fluid-filled interior. Since it is a normal variant, it will be asymptomatic, and we know that this answer is incorrect because it's generally found below the inferior alveolar nerve canal like we're seeing in the radiograph. Finally, we have the residual cyst, and this occurs in a region where there used to be a tooth with a radicular lining or fluid-filled interior. Since it is a normal variant, it will be asymptomatic, and we know that this answer is incorrect because it's generally found below the inferior alveolar nerve canal like we're seeing in the radiograph. Finally, we have the residual cyst, and this occurs in a region where there used to be a tooth with a radicular cyst, and then this tooth was extracted, but there was incomplete removal of the cyst, so there's just reoccurrence. So because it is a cyst, it will be radiolucent. It's generally occurring in the maxilla, and it will be asymptomatic. It will look like a radicular cyst, so unilocular, radiolucent, well-defined, and we know that this is incorrect because with the patient history, we have no notes of a previous inflammatory cyst, so this would be an incorrect answer. So now we know what all these pathologies look like and how to diagnose them. Cyst, so unilocular, radiolucent, well-defined, and we know that this is incorrect because with the patient history, we have no notes of a previous inflammatory cyst, so this would be an incorrect answer. So now we know what all these pathologies look like and how to diagnose them.
This question is asking which complication is most likely to arise from reactivation of the varicella-zoster virus, which is also the virus that causes chickenpox: diarrhea, postherpetic neuralgia, Bell's palsy, or osteoradionecrosis of the jaw. Now, before we can discuss what complication is most likely to arise from reactivation of this virus, we should start by discussing just what reactivation of this virus presents as. And reactivation of the varicella-zoster virus is more commonly known as herpes zoster or shingles, and it occurs in 10 to 20% of the population who's had chickenpox, with an increased frequency seen as a patient gets older. It is a reactivation because it's due to the same virus that originally caused chickenpox in a patient that remains dormant in the body for years before eventually reactivating to cause symptoms. Shingles is characterized by painful erythema and vesicles, usually on the trunk or head and neck region. Other symptoms include burning or shooting pain, tingling or itching, with some people also experiencing fever, headache, and chills. A characteristic feature of shingles is that the lesions characteristically stop at the midline of the body. This is because the virus travels along a certain dermatome or area of skin innervated by a single spinal nerve dorsal root, so they would not cross the spine. Treatment for this condition is systemic acyclovir if early in the course of the disease, and it has a good prognosis, with the lesions resolving in about 2 to 3 weeks. But, as the question points out, there can be complications associated with the condition. The most common complication is B, postherpetic neuralgia. This develops 15% of the time in people with shingles and is severe pain that persists more than 3 months after onset of the rash. It usually subsides on its own, but it can even persist for years for some people and will interfere with their daily life. Now, when trying to remember that postherpetic neuralgia is a complication of shingles, it may be helpful to keep in mind that the official name for shingles is herpes zoster, so it makes sense that it's postherpetic neuralgia. Now, although shingles can be associated with other complications, such as vision loss if the virus affects the eye, hearing or balance problems if the virus affects the ear, and rarely pneumonia or encephalitis, it is not associated with any of these other answer choices. But let's still go through them quickly. We'll start with diarrhea. This is a pretty straightforward symptom, and it's just not one that is associated with shingles. As we discussed earlier with dermatomes and the virus lying dormant in the root ganglia, this condition primarily affects the nervous system and the skin, not the gastrointestinal system. Because this is not a complication seen with shingles, we know this answer choice is incorrect. Next, we have Bell's palsy. Bell's palsy is paralysis of the facial nerve, or cranial nerve 7, which is mainly responsible for motor innervation to the muscles of facial expression. This facial paralysis or muscle weakness is typically idiopathic and will affect one facial nerve, meaning only half the face will be affected. This also causes facial drooping, lack of motor control, drooling, and dry eye, but the problem usually resolves on its own. Now, this answer choice may have been a little tricky because you may be familiar with something known as Ramsay-Hunt syndrome, and this is what happens when the herpes zoster virus affects the facial nerve near one of the ears. This can also cause facial paralysis, and it can cause hearing loss, tinnitus, difficulty closing the eye, dry eyes, and vertigo, alongside the characteristic painful blistering rash seen in a traditional shingles infection. Now, although this presents similarly to Bell's palsy itself is not a complication of shingles. It has no association with shingles, and it's usually idiopathic. If a patient is presenting with symptoms seen in Bell's palsy, such as that facial paralysis, but it's due to reactivation of the herpes zoster virus in the facial nerve, it would then be Ramsay-Hunt syndrome. Ramsay-Hunt syndrome will also present with a few symptoms not seen in Bell's palsy, such as hearing loss, ringing of the ears, and that characteristic shingles rash. So because Bell's palsy is not associated with shingles, it would not be a common complication of shingles, and the answer choice is wrong. And finally, we have osteoradionecrosis of the jaw. First of all, if we start just by looking at the name of this answer choice, it kind of tells us itself why it would be incorrect for this question. If we break down osteoradionecrosis, osteo refers to bone, radio refers to radiation, and necrosis refers to death of tissue. So this would be the death of bone tissue in the jaws due to radiation, not due to a virus such as shingles. This results due to a reduction in vasculature, bone remodeling capacity, and mineralization due to cellular bone damage, and it's often the result of head and neck radiation therapies used to treat certain cancers. Because this necrosis is associated with radiation and is not associated with the reactivation of the varicella-zoster virus, we know that this answer choice is also incorrect. So we know that when discussing the complications arising from shingles or the reactivation of the varicella-zoster virus, the most common complication is postherpetic neuralgia, or this severe persisting pain. This question is asking which is the most common chromosomal abnormality, XYY syndrome, trisomy 18, trisomy 21, or trisomy 13. Now, the most common type of chromosomal abnormality in general is known as aneuploidy, which is an abnormal chromosome number due to an extra or missing chromosome, which we see is the case for all 4 answer choices. And if you don't know what trisomy means, it just means that there are 3 copies of a chromosome instead of the regular 2, 1 from each parent. Now, out of these 4 answer choices, the most common chromosomal abnormality is one that you're likely very familiar with, and that is C, trisomy 21, or it is most commonly known as Down syndrome. Now, in babies with this condition, they have inherited an additional chromosome at position 21 instead of just the pair that is typically seen. This syndrome is seen in 1 out of every 691 births, and the risk for this syndrome increases as the age of the mother increases as well. Symptoms of this condition include a flattened face, almond-shaped eyes that slant upwards, a protruded tongue, a short neck, mild to moderate intellectual disabilities, musculoskeletal and movement problems, congenital heart diseases, and shorter than average height. Dental problems associated with this condition include delayed eruption of both dentitions, hypodontia and microdontia, macroglossia, malocclusion due to a small maxilla, and an increased risk for periodontal disease. Treatment for this condition involves a multidisciplinary team and is based on each individual's physical and intellectual needs. And because this is the most common chromosomal abnormality, we know this is definitely the correct answer choice. But let's go ahead and go through these other answer choices and discuss what each of these syndromes are as well. We'll start with XYY syndrome. In this syndrome, instead of a male having just 1 X chromosome and just 1 Y chromosome, they have 2 Y chromosomes. This syndrome occurs in about 1 in every 1,000 births. Clinical features associated with this syndrome include learning disabilities, behavioral problems, above average height, and aggressive acne during adolescence. The behavioral problems associated with the condition can include impulsivity, hyperactivity, an explosive temper, or antisocial behaviors. These individuals can also have an increased risk of having dyslexia, ADHD, and autism spectrum disorder. Although developmental years can cause some social difficulties for these patients, they typically lead healthy lives with a normal lifespan. Treatment is mainly centered around any learning disabilities seen in these patients. Because this is definitely not as common as trisomy 21, this answer choice is incorrect. Next, we have trisomy 18, which is also known as Edwards syndrome, and this is the result of having an extra chromosome, 18. This occurs in 1 out of every 5 to 6,000 births. It is more common during pregnancy, but most fetuses with this condition unfortunately do not survive full term due to complications from the diagnosis and will either be miscarried or stillborn. Symptoms include poor growth before and after birth, severe developmental delays and learning problems, decreased muscle tone, internal organs forming or functioning differently, overlapping fingers, club feet, breathing abnormalities, scoliosis, and congenital heart disease. This is a severe genetic condition that affects how the body develops and grows, and the life expectancy of children born with this condition is short due to these life-threatening complications. Unfortunately, most infants don't survive past a week, and about 90% will die within a year. Now, because this answer choice is definitely not as common as trisomy 21, it would be incorrect. And next we have trisomy 13. This condition is also known as Patau syndrome and is the result of an extra copy of chromosome 13 being present alongside the normal pair. This is seen in 1 to every 10,000 to 20,000 births, so it's not very common, and it affects the development of the face, brain, and heart alongside causing physical growth abnormalities. Symptoms seen in this condition include extra fingers or toes, a small head and jaw, low muscle tone, cleft palate, congenital heart defects, spinal cord growth issues, severe cognitive impairments, and underdevelopment of the internal organs. Unfortunately, the symptoms of this condition are life-threatening and may result in miscarriage or death before the infant turns 1. Only 5 to 10% of babies born with this condition survive past their first year. And because this is definitely not as common as trisomy 21, this answer choice is also incorrect. So we know that when we're talking about chromosomal abnormalities, the most common is trisomy 21, which is more commonly known as Down syndrome. This question is asking which oral lesion is most likely to become malignant: leukoedema, smoker's keratosis, leukoplakia, or erythroplakia. Now for this question, I'm just going to tell you straightforward which one is the most likely to become malignant, and then we'll go ahead and talk through each of the answer choices, what they are, and how likely they are to become malignant. Now, the most likely to become malignant out of these options is erythroplakia, and I've attached a picture of what one looks like. Now, erythroplakia is a pre-malignant epithelial lesion that typically displays severe dysplasia. Now, epithelial dysplasia are disturbances of epithelial proliferation and maturation that can be seen microscopically, and there are different stages of dysplasia as it gets more severe. Now, think about cancer. These are pre-malignant lesions, but they can become malignant. So when you think of cancer cells, you have this dysplasia, this growing, this changing, and that's what we're talking about. Now, although oral squamous cell carcinoma may develop from any grade or severity of dysplasia, it is much more likely to develop from severe dysplasia, which is what we're seeing usually in erythroplakia. Now, the progression for this severity is typically a leukoplakia, which is a white lesion that we'll talk about later because it's one of the answer choices. Then it goes from leukoplakia to erythroleukoplakia, which is red and white, erythro meaning red, leuko meaning white, and then from erythroleukoplakia we go to erythroplakia, which is just a red lesion. So clinically, for erythroplakia, if we look at this image, we see this velvety red lesion due to the lack of keratin production on the surface of the lesion. The mucosa of the lesion is atrophic, or it's thinned, and the underlying vasculature is showing through. It's also known to be well demarcated. If you look at the picture, you can kind of see where the lesion starts and ends, and it's usually asymptomatic. And it's also most commonly seen on the lateral tongue, the floor of the mouth, or the soft palate. So that's erythroplakia, and it has a pretty high occurrence of becoming malignant because it is that severe dysplasia. Now let's talk about the other answer choices. And we'll start with leukoedema, and I have a picture of it we can see here. Now, leukoedema is this diffuse, grayish or milky white appearance to the oral mucosa with these surface folds or wrinkles, and it's due to fluid accumulation within the epithelial cells of the spinous layer. Now, think about the name that we're seeing here. Leuko just means white, like we said, and edema means that fluid is trapped, so that kind of makes sense of what leukoedema would be. Now, this is very common, and it's seen even more in people with more melanin content in their skin, and it's honestly likely just a variation of normal. This isn't a concerning finding when we see it. And we also see this most commonly on the buccal mucosa, and it's often a bilateral finding, so you can see it on the buccal mucosa in this picture. This also seems to be more common and more pronounced in smokers, but still not something that we're concerned about when we see it. To confirm, you can confirm the diagnosis of leukoedema by stretching or distending the mucosa. So you just take your finger and you kind of stretch their mucosa, and if the whitish appearance disappears, then you know that it's leukoedema. You're stretching it, the fluid's like distending, and you don't see this white, grayish, or milky gray appearance anymore. Now, there is not a concern for malignant transformation that we're aware of for leukoedema, and it does not require any treatment. So it's definitely not the most likely to become malignant. Now we'll talk about smoker's keratosis. You might also know this as nicotinic stomatitis. They're the same thing, so that's a different name I would know it by. And in this, we see this diffuse white appearance to the palatal mucosa, and the surface may be wrinkly or fissured. But characteristically, it's known for having these elevated papules with punctate red centers, and these red centers represent inflamed minor salivary gland orifices. Now, this is associated with smoking. It's called smoker's keratosis or nicotinic stomatitis, but it's actually a response to the heat generated when you're smoking and not due to the chemicals of the tobacco. So we see this more in patients who smoke pipes, who smoke cigars because they're getting more of that heat, but we also see this in people who chronically drink really hot beverages. So if you always drink really hot tea or really hot coffee, you might not be a smoker, but you're still likely to get smoker's keratosis because it's due to the heat generated and not to the chemicals in the tobacco. Now, kind of like the leukoedema, this is a benign epithelial lesion, and it's not precancerous. This doesn't require any treatment when we see it, and if the habit is stopped, if they stop drinking these hot beverages or they stop smoking, the condition will actually resolve in about 1 to 2 weeks because the minor salivary glands will no longer be inflamed. Now, finally, let's talk about leukoplakia. Now, this was the tricky other answer when we were answering this question because it is similar to erythroplakia. So this was the other one that you might have had in mind. Now, leukoplakia is the most common oral precancerous lesion, and a biopsy is always mandatory for diagnosis. But I want to stress that this is a clinical term only. There's no diagnostic value when you say leukoplakia. It's not a diagnosis. It's a clinical term. It's a descriptive term. And clinically, we see this white plaque with these sharply demarcated crisp borders. If you think of the term leuko, I said means white, and plakia means like a patch. So that makes sense. That's what we're seeing. And this can be flat to slightly elevated. It can be smooth or have have a wart-like surface, and it has that white color due to thickened keratin. And that white color, this white plaque, cannot be wiped off. That's a really important detail because you'll see white plaques in the mouth pretty often, and it's usually due to a candidiasis infection, and that can be wiped off. That's a fungal infection. Those are known to be able to be wiped off, but in a leukoplakia, it does not wipe off. And like I said, this cannot be diagnosed clinically or microscopically as any other condition. This dysplasia, we get this leukoplakia descriptive term kind of by exclusion. We rule out everything else and we just determine that this is just dysplasia. We're just seeing this leukoplakia. And overall, the buccal mucosa is the most common overall site, even though in this picture we see it in the tongue. Now, some risk factors for this, you can be a male over 50, that's a risk factor, but the highest risk factor is tobacco use, is smoking. More than 80% of patients with leukoplakia are smokers. So that is a big risk factor, especially cigarette smoking. Now, back to the question. Although this is a precancerous lesion that can absolutely become oral squamous cell carcinoma, this is when we find this, we want to make note of it. It is important and something we want to follow. It has less dysplastic change than the erythroplakia. So we don't see as much dysplasia as we saw in erythroplakia, and that means that this is less likely to progress directly to a malignancy like erythroplakia was. So it's more like leukoplakia is more likely to become erythroplakia than to become oral squamous cell carcinoma. So once again, I just want to highlight that we see erythroplakia having more severe dysplasia. Plakia is more likely to become erythroplakia than to become oral squamous cell carcinoma. So once again, I just want to highlight that we see erythroplakia having more severe dysplasia, so it's more likely to become a malignancy, and usually the sequence goes leukoplakia, erythroleukoplakia, and then erythroplakia. But leukoplakia can still become oral squamous cell carcinoma, so it is a concerning finding, but erythroplakia is much more concerning because it's much more likely to become a malignancy. We have a 25-year-old female who's here for an exam. She has sickle cell anemia, she's taking a medication, and she has generalized gingivitis. And we're asked, which is a common radiographic finding associated with the condition on panoramic images? Now, the condition we're obviously being asked about is sickle cell anemia, and before we discuss how it presents on a panoramic image, let's discuss what it is. Sickle cell anemia is a group of inherited disorders that affect hemoglobin, which is the protein responsible for carrying oxygen in your red blood cells. These cells are typically disc-shaped and flexible, allowing them to easily flow through the blood vessels, but in sickle cell anemia, they have a crescent or sickle shape, which gives the disease its name. The defect in the shape of these cells prevents them from bending, from being flexible, and provides difficulties when they're moving through the blood vessels, and it can lead to a number of complications, even including a stroke. The anemia in this condition is the result of the reduced lifespan of sickle cells, meaning the body gets less oxygen and is often fatigued. Other symptoms include episodes of pain due to blocked vessels, swelling of the hands and feet, vision problems, delayed growth, and frequent infections. Dentally, symptoms include mucosal pallor, delayed tooth eruption, malocclusion, hypercementosis, disorders of enamel and dentin mineralization, and radiographic changes such as a loss of fine trabeculae and formation of large bone marrow spaces. And here's an example of a panoramic image. Now, this is a chronic condition, but treatment aims to reduce or manage the symptoms to increase longevity of the patient. Treatment includes medications, blood transfusions, bone marrow transplants, and gene therapies. But going back to the question being asked, we can look at this panoramic image. What is a common radiographic finding associated with sickle cell anemia? And we know, based on what we talked about, that the correct answer choice here would be D, loss of bony trabeculae. Now, this occurs due to the fact that the blood cells have such a short lifespan, like we discussed, making the bone marrow expand as a compensatory mechanism, replacing trabecular bone or resulting in its loss. We get a loss of trabecular bone. This loss of bone trabeculae can be seen on this panoramic image here, and although this is definitely the correct radiographic finding for sickle cell anemia, let's go ahead and go through the other answer choices and discuss when those radiographic findings would be seen. We'll start with dense osteosclerotic islands. Now, another name for these dense bone islands is idiopathic osteosclerosis, which is something you should likely be familiar with. These are focally increased areas of dense bone that have an unknown cause and are usually found incidentally on a radiograph. They're most commonly seen as radioopacity in the mandibular premolar or molar area, and they are asymptomatic. These require no treatment and have an excellent prognosis, but this answer choice would be incorrect because these dense osteosclerotic islands have nothing to do with sickle cell anemia. Next, we have multiple small and well-defined radiolucencies. Now, multiple small and well-defined radiolucencies are also commonly described as punched-out radiolucencies and are a common finding in multiple myeloma, a cancer of the plasma cells. These radiolucent areas contain abnormal plasma cell proliferations, and widespread lytic lesions of bone are characteristic of this condition. This answer choice would be incorrect because these multiple small, well-defined radiolucencies are not associated with sickle cell anemia at all. And then finally, we have numerous supernumerary teeth. Now, supernumerary teeth can be a somewhat normal finding, but numerous supernumerary teeth are usually associated with an underlying condition, such as cleidocranial dysplasia or Gardner syndrome. Although sickle cell anemia can cause delayed eruption of the teeth as well as disturbances in the mineralization of enamel and dentin, it does not cause numerous supernumerary teeth, making this answer choice incorrect. So we know that when talking about sickle cell anemia, a panoramic radiograph will show the loss of bony trabeculae. This condition is not associated with dense osteosclerotic islands, multiple small and well-defined radiolucencies, or numerous supernumerary teeth.
We are given this image here and we're to find out which of the following options is the most likely diagnosis. So the patient does have braces and just is in for a checkup, so we can tell that this might be an incidental finding. With the clinical findings, we can see that the patient does not have pain and also presents with a positive pulp vitality test, so we know that the tooth is alive. The crown does appear pink, which can be indicative of the presence of blood. So the correct answer here is internal resorption. And here we have destruction, but it comes from inside the root, so the dentin walls are destroyed. It can occur due to trauma and infection, but also due to orthodontic forces, which the patient does present with. And it's usually asymptomatic, which is why the patient isn't complaining of any pain. As we can see in the radiograph, we'll have an alteration in the shape of the root canal, and we'll also have an enlarged radiolucent area. And internal resorption can present with a pink appearance if the blood vessels are able to fill the crown due to the resorption. We'll just take a look at the other answers to see why they are incorrect. So with external resorption, it is similar to internal resorption. It can occur with trauma, infection, periodontal infection, and also orthodontic treatment as well. But we know that this is an incorrect answer because of the radiographic appearance. So the root canal would not have that large radiolucency that we see in the patient. In addition, the resorption will occur from outside of the root, making it look short and blunt. And this is caused by the loss of the cementum layer that surrounds the root. Next, we have subluxation, which occurs due to trauma to the teeth and the periodontal tissue, so layer that surrounds the root. Next, we have subluxation, look short and blunt, and this is caused by the loss of the cementum layer that surrounds the root. Next, we have subluxation, which occurs due to trauma to the teeth and the periodontal tissue, so the patient will present with pain and a damaged periodontium. And in cases of subluxation, the tooth may feel loose, but it'll remain in the original position. What we will see is bleeding near the gum line due to damage to the gums, and generally we wouldn't see any radiographic signs, and we'll need to rely on clinical examination and good history taking to diagnose this. Finally, we have ankylosis, which is when the tooth structure is replaced by bone, so the dentin and cementum of the root are fused with bone. And this can be due to trauma, but it also has a genetic origin. And since bone is made out of hard tissue, we would expect to see a radio-opaque appearance rather than a radiolucent appearance. Clinically, we would see a lack of mobility when it comes to the tooth, and then we can see here in the radiograph that the roots are highly radio-opaque and resorption is evident. So now we know what all these pathologies look like radiographically, and we can identify them in the future.
This question is asking which is a common symptom of hypoglycemia: fruity smell in the breath, increased thirst, confusion, or frequent urination. Now this is a great question, as hypoglycemia is an important complication of diabetes that we need to be able to recognize as dental professionals. So let's start by talking about diabetes and then talk more specifically about hypoglycemia and its symptoms in a bit. Now, diabetes is a group of metabolic disorders resulting in hyperglycemia, and it's a defective or deficient production of or response to insulin. Insulin is a major anabolic hormone that allows glucose to be transported and stored in cells within the body after meals. There are two major types of diabetes, which I'm sure you're familiar with, type 1 and type 2. Type 1 diabetes is a chronic autoimmune disease where the beta cells of the pancreas get destroyed by self-reactive T cells and autoantibodies. This results in absolute deficiency in insulin production. This is typically seen in younger patients and is characterized by decreased blood insulin. Type 2 diabetes is not an autoimmune disease and is either the result of insulin resistance or decreased insulin secretion. The target tissues may not be responding to the produced insulin, or the pancreas may not be producing enough insulin for their body to function. This is seen in older patients and is associated with obesity, but the insulin levels in the blood may be normal or increased depending on the cause of the condition. Both types of diabetes can have a number of complications and symptoms. Diabetes is the leading cause of end-stage renal disease, blindness, and lower limb amputation, and a number of other complications are also seen. As far as symptoms, the 3 P's of diabetes are very common and likely the most well-known symptoms, and they would be polyphagia, which is extreme hunger, polydipsia, which is extreme thirst, and polyuria, which is increased urine production. Now, hypoglycemia specifically is also known as low blood sugar, and although we're most often concerned about this occurring in diabetics, it can occur in anybody. It's seen most often in diabetics due to too much insulin or too little food, but anybody who has not eaten in a while can experience hypoglycemia. The symptoms include hunger, weakness, sweating, incoherence, irritability, belligerence, confusion, and if it becomes severe enough, it can lead to tachycardia and an unconscious state. Thankfully, this can usually be treated pretty easily by just giving the patient a source of glucose, such as a glass of orange juice. So based off of everything we just said about hypoglycemia, we know that the correct answer choice here would be C, confusion. And even if you knew nothing about diabetes or the common symptoms seen in this condition, just think about a time when your blood sugar was really low and you were super hungry. You probably felt a little bit out of it, probably confused or disoriented, maybe even about to pass out. We've all likely been hypoglycemic at least once in our lives, and I doubt you experienced a fruity smelling breath, increased thirst, at least that was due to the hypoglycemia, or frequent urination when this occurred. Beyond just this logically making sense, the confusion that occurs in hypoglycemia is actually due to the brain not getting enough energy to function, leading to this disorientation and possible other mood or neurological symptoms. So because confusion is definitely a symptom seen in hypoglycemia and the other answer choices are not, we knew that this answer choice was correct. But let's still go through the other answer choices and discuss why they were incorrect here. We'll start with that fruity smell in the breath. Now this is a very interesting symptom, and it's actually something that a patient experiences when they are hyperglycemic, not hypoglycemic. This is typically a sign of diabetic ketoacidosis, which is a serious complication that results from long-standing or severe hyperglycemia. It occurs when the body does not produce enough insulin. If glucose is unable to be transported and stored, the body is unable to use it as an energy source for the body. When this is the case, the body will have to turn to other sources of energy, and it will tell the liver to break down fats into ketones for the body to use. These ketones are acids, and they will build up in the bloodstream and cause what is known as ketoacidosis. Keto referring to the ketones that are a byproduct of the fats, and acidosis referring to the acidic level of the blood that results. This is a condition that often comes on very suddenly, even within 24 hours. Symptoms of ketoacidosis include being very thirsty, increased urination, nausea or feeling the need to vomit, confusion, fruity smelling breath, fatigue, and stomach pain. This fruity breath occurs because these excess ketones, they have this distinct fruity or nail polish remover-like odor, which can be noticed in the person's breath. So because this symptom is instead associated with hyperglycemia and not hypoglycemia, we knew that this answer choice was incorrect. Next, we have increased thirst. Now, we talked about polydipsia, or excessive thirst, earlier when we talked about the symptoms of diabetes. And remember, untreated diabetes is defined by hyperglycemia because there is insufficient insulin for the amount of glucose present. So thirst would also be a symptom of hyperglycemia rather than hypoglycemia. This is usually occurring because the body tries to compensate for high blood sugar by excreting glucose through urine. This draws water along with the glucose, leading to dehydration and triggering the sensation of thirst. So because this is another symptom associated with hyperglycemia instead of hypoglycemia, we knew that this answer choice was incorrect. They'd find that we have frequent urination, and this is a final symptom that is also associated with hyperglycemia and not hypoglycemia. This is that polyuria we also talked about earlier alongside the polydipsia, and this goes hand in hand with what we were just discussing about polydipsia. The excess glucose in the body that the kidneys are unable to absorb will be excreted in the urine, and because there is so much excess glucose that needs to be excreted, a diabetic will have an increased need to urinate. In hypoglycemia, the body is more focused on the immediate stress response, which causes that shaking, that confusion, that sweating, and it's not focused on more rest and digest functions like urinating. So because this is not seen in hypoglycemia, we knew that this answer choice was also incorrect. So we know that when talking about hypoglycemia or low blood sugar, confusion is a common symptom. Fruity smell in the breath, increased thirst, and frequent urination are all not common symptoms of hypoglycemia, but are instead experienced in a hyperglycemic state. We have a 10-year-old female whose parent says, "My daughter is here for a checkup. She also has a sore throat and does not feel good. She's a fever, she's had malaise for the past 2 days, she has bilateral enlargement of her tonsils and a strawberry tongue." The dentist refers the patient to their physician for the complaint of a sore throat. The patient is given a 7-day course of amoxicillin, which is taken by the patient only for 1 day due to a busy schedule. The patient returns 4 weeks later for a new exam and complains of pain in her knees and feet, involuntary muscle movements, and a red rash on her stomach. What is the most likely cause of these new signs and symptoms? Now, this is a great question and one that really stresses the importance of taking and completing a course of antibiotics. Even if you have a busy schedule or if you start to feel better, you need to complete a course of antibiotics or the infection may not fully go away, and this behavior can contribute to antibiotic resistance. In this scenario, that is exactly what's happening. The patient only took 1 day of a 7-day course, and the bacteria causing the original infection were not fully eliminated, likely becoming more resistant, and are now presenting as a more serious illness for the patient. We're given a lot of helpful information to determine both the original illness and the new illness, but since the patient box information refers to the original illness, we'll start there. It's very obvious from everything in this patient box that our patient is sick. She has a fever, she has malaise, which is just a general unwell feeling, her tonsils are swollen, but what information here really allows us to narrow down the illness that she had? The first is the fact that she has a sore throat. Now, this may not seem very indicative of a certain condition, but our correct diagnosis is honestly one of the first we consider when a patient has a sore throat. And when it's seen in tandem with another symptom of this patient, the strawberry tongue, which we can see in this image, we can be almost certain of the diagnosis even before doing any testing. A sore throat, in combination with that characteristic strawberry tongue, indicates a streptococcal pharyngitis infection, which is commonly known as strep throat. This infection is most common in children, but can affect any age and is spread through droplets or shared food and drink. Beyond the sore throat and strawberry tongue, other clinical signs of this condition are painful swallowing, swollen and red tonsils, headache, fever, nausea or vomiting, body aches, and palatal petechiae. It is treated with antibiotics, such as the 7-day course of amoxicillin the patient was originally prescribed, and if untreated, it can lead to complications, including the new illness our patient is presenting with. But what is this new illness? That's what the question is asking about. Now, even if you didn't know what untreated streptococcal pharyngitis can lead to, we're given very descriptive symptoms to be able to diagnose what this patient has. She has pain in her knees and feet, involuntary muscle movements, and a red rash on her stomach. Given these symptoms and her history of strep throat, we know that this patient is currently suffering from rheumatic fever. Now, just based off the name, the fact that she's suffering from joint pain in her knees and feet makes sense. Similar to rheumatoid arthritis, rheumatic refers to inflammation and pain in the joints. Rheumatic fever overall can develop if strep throat or scarlet fever and possible other group A streptococcus infections go untreated, and it's an inflammatory condition that can affect the joints, heart, brain, and skin. It's thought to be an immune response to an untreated infection, and therefore cannot be spread from one person to another. You cannot catch rheumatic fever. This condition typically presents about a month after the original infection, but can present anytime 1 to 5 weeks later. The characteristic clinical signs are arthritis, which is that joint pain, jerky and uncontrollable body movements, fever, and fatigue. A rash can also be seen, as we see in our patient, and heart-related symptoms include chest pain and tachycardia. If this also goes untreated, even more serious complications can present as rheumatic heart disease, which can require heart surgery and even result in death. This is treated mostly by treating the symptoms with medications to reduce inflammation, fever, and pain, but if the patient still presents with a positive strep test, then they would be given antibiotics to eradicate that infection as well, and they need to take that full course of antibiotics. Now, although this is definitely the correct answer, let's go through the other answer choices and discuss what they are and why they are incorrect. I'll start with scarlet fever. Now, this was definitely a tricky answer, as rheumatic fever and scarlet fever are quite similar, but the major difference is that scarlet fever is due to streptococcal pharyngitis infection, while rheumatic fever is an immune response to an untreated streptococcal pharyngitis infection. So if a patient has scarlet fever and doesn't receive treatment or doesn't take their full course of antibiotics, they could develop rheumatic fever as a result. We discussed streptococcal pharyngitis causing strep throat, but didn't discuss it causing scarlet fever. So what is the difference? These are basically the same condition, but when it's termed scarlet fever, if the patient is infected with strep and they have a rash. The rash is what makes it scarlet fever. This is because this is a bright red rash that can cause involuntary muscle movements, so we knew this was not the answer. Or involuntary muscle movements, so we knew this was not the answer. Next we have endocarditis, and we can break down the name of this to understand what it means. Itis refers to inflammation, and endo refers to endocardium, or the inside lining of the heart chamber and valves. Hopefully, you've heard of this before because there is a lot of emphasis in dentistry on prophylactic antibiotics concerning this condition. This inflammation is usually due to a bacterial infection, but can also be due to a fungal infection. These bacteria can enter the bloodstream during surgery, requiring venous access, via injection drug use, during dental surgery, and other procedures. People who are the most at risk are patients with a birth defect of the heart, a damaged heart valve, a history of endocarditis, a new heart valve after surgery, or other heart issues. Common symptoms of endocarditis include fever, chills, sweating, fatigue, weakness, weight loss, loss of appetite, aches and pains. Other symptoms that are more specific include areas of bleeding under the nails, red skin spots on the palms and soles, and more noticeable things like that. Treatment for this includes long-term antibiotic therapy and possibly even surgery, but the prognosis is typically good if it's treated immediately. Now, we know this is not the correct answer because there is no indication that the patient is experiencing endocarditis. She does not have a history of any heart problems, and we were not given any indication that she has recently had a procedure that may expose her to a bacterial infection. Although some of the original symptoms may be similar, the exact symptoms she was originally experiencing are much more indicative of a strep throat infection. And the symptoms she is experiencing now due to rheumatic fever, such as the joint soreness and involuntary muscle movements, are not associated with endocarditis. Endocarditis is also not the result of an untreated infection, so we know this is the incorrect answer. And finally, we have an allergic reaction to amoxicillin. Amoxicillin or penicillin allergies are pretty common occurrences and can present in a number of ways depending on the severity of the allergy. The signs and symptoms associated with an allergic reaction to these medications usually occur within an hour of taking the first dose of the drug, but can very rarely occur hours or days later. Common clinical signs of this reaction include a skin rash, hives, itching, fever, swelling. Amoxicillin or penicillin allergies are pretty common occurrences and can present in a number of ways depending on the severity of the allergy. The signs and symptoms associated with an allergic reaction to these medications usually occur within an hour of taking, very rarely occur hours or days later. Common clinical signs of this reaction include a skin rash, hives, itching, fever, swelling, shortness of breath, wheezing, runny nose, and in the most severe cases, anaphylaxis with joint soreness, involuntary muscle movements, possibly a rash, and had a history of untreated streptococcal pharyngitis condition, we know that they're experiencing rheumatic fever. This is a condition that can easily be prevented by adequately treating group A strep infections and being sure to complete the entire antibiotic regimen that is given. We have a 75-year-old female who says the corners of my lips hurt. She has hypertension, a penicillin allergy, she's not taking any new medications or using any new toothpastes, and she has a poorly fitting mandibular partial denture. This question is asking what condition is shown in the image given. Now, obviously, our biggest clue is the fact that the corners of her lips hurt. That's a very specific place, and the fact that they're hurting alongside this image really helps us make that diagnosis. And the fact that she also has a poorly fitting mandibular partial denture is also just another little hint as to what the diagnosis is. And here, it's angular cheilitis. Now, this is usually related to candidiasis. It can be contributed by other bacterial microflora, but it's usually candidiasis, so that's what we're going to focus on. Now, candidiasis is a very common yeast, and whether a candidiasis infection develops and its severity depends on your immune status, oral mucosal environment, the virulence of the fungal strain, but overall it's just a really opportunistic fungal infection that we see a lot in dentistry. Now there are different presentations of candidiasis. The most common is actually pseudomembranous candidiasis, but we're going to focus on a lesser common form known as erythematous because angular cheilitis is an erythematous form of candidiasis, so that's the one that we're going to focus on. Now erythematous candidiasis is characterized by an area of redness with variable borders. The